Doing well despite all the issues we're having with COVID around here. Anyways, I guess most people know who I am, so I'm not gonna dwell on that. And I'm just gonna take it on and talk a little bit about Chagas disease, which has been something that I've been working for a few years now, I guess. And where my conflicts of interest are primarily that most people know that I've been working on the benefit trial for several decades and the Stop Chagas trial, and actually started with something I called the charity trial that I'll show you some of that in a little bit. I also sit in a couple of advisory boards for DNDI, which is drugs for neglected diseases. And as you may guess, Chagas cardiomyopathy kind of falls within the neglected diseases. I'm also a member of the advisory council of the Infectious Disease Data Observatory at Oxford University, and I chaired the DSMB of a couple of trials that are looking at new therapies in Chagas. And I am currently a member of the executive committee and a co-PI of the Parachute heart failure trial that is sponsored by Novartis, and I will talk about that a little bit. And I've been involved with guidelines and the World Heart Federation roadmap for Chagas and other things within this. So a little bit of an overview of Chagas kind of 101 epidemiology for those of you that are not that familiar with the disease. Excuse me. I'll primarily focus on what I've been doing for the last few decades in Chagas and how did I begin to get involved with Chagas disease. Something about the etiologic treatment of the parasite. How do we risk stratify? Something about biomarkers and disease progression, heart failure management, and a little bit of provocation and speculation within reason. And where do we think we want to go in the future? Now, you all know that this is Darwin. There's a big discussion on whether Darwin actually died from heart failure related with Chagas cardiomyopathy. And as he wrote in his journal, you can read there that at night he experienced the attack of the vinchuca, which is how they call their redovirus, which is the bug that carries the parasite, when he was exploring the pampas in Argentina. So we'll never know if he really died from Chagas cardiomyopathy heart failure, but makes a good story. Anyways, you all know what's the life cycle of the trypanosoma, how it is transmitted. So this bug, really what happens is that it comes when you're sleeping and it bites you, and it starts to suck your blood. So this bug kind of bloats up a lot, and when he bloats up, he defecates, and that's actually what is going to transmit the disease, because the defecation is going to give you an urge to scratch, and when you scratch your skin, you break the dermis there, and the mastigote and the trypanosoma is going to get into the bloodstream. That's how this happens. But of course, this doesn't happen with a single bite of a bug. When we used to go to these little huts near the place where I used to work back in northeastern Colombia, these are infested with thousands of these bugs. So it's the chronic exposure to this that will lead to the disease. So some people ask me, I'm going to go to whatever Bolivia and do some camping and stuff. Am I going to get Chagas? So probably not. So don't worry about that. Now, we do know that there's some geographic distribution, which is important. And there are 6 types of the strain. And there's been a lot of discussion on whether these called DTUs have a different, not only distribution geographically, but if this actually has anything to do with the progression of the disease, the amount of parasite load, the pathophysiology, and the performance of diagnostic testing and the response to treatment. And we will try to deal with that a little bit. Again, for those that are not familiar with the disease, it has an acute phase. Most of the time it goes by mostly asymptomatic, but it can present as a prolonged fever syndrome. It's obviously related with vector transmission. There's also congenital transmission. And today there's oral transmission. There's been some reports that, people get some of these fruits, they crush it, and then end up crushing some of these bugs that had the trypanosome. And this has led to some acute infections, which manifest with this, palpebral edema known as the Romagna sign. And, sometimes some of these little kids end up having an acute myocarditis, but again, that's pretty rare in the acute phase. So the acute phase, by and large, goes by asymptomatic, and then 20 or 30 years later, 20 to 30% of the people that are infected, and we don't know why, and that's one of the mysteries that we've been trying to unravel, is that they will end up having some ECG changes, typically right bundle branch block with a left anterior fascicular block, which were described by Mauricio Rosenbaum in the mid-50s. And this was the initial description of that combination of right bundle branch block, some PVCs, and sometimes digestive forms. For example, the T cruzi 1, which is the one we see over the equator, so that would be Colombia and Central America. We rarely see the mega visceral kind of things. We usually see the cardiac form. But under the equator, you're going to see more of a mix in a combination, again, depending on the strain of T cruzi. And again, it may be reactivated and with co-infections like HIV and other causes of immunodeficiency like transplant. So it is a disease that has a significant alteration. So once you get infected, you'll get a serology. That serology is basically just looking at your antibody response. And you go into something we call the chronic indeterminate stage. And that chronic indeterminate stage, most of the time, there's going to be a subdivision between those that have ECG changes and those that do not have ECG changes. So by and large, most people won't have any of these changes, and 70, 80%, nothing's going to happen. They're going to have these serological tests that are going to remain positive throughout the rest of their life. Now, 20 to 30 years later, there's about 20 to 30% of the population. It's going to end up having a cardiomyopathy. And this is a very aggressive, non-ischemic dilated cardiomyopathy that has different stages, as you can see here, B1, B2, C, D, etc., in which some of these patients rapidly progress into heart failure and refractory heart failure, characterized by conduction disorders and ventricular tachycardia and arrhythmias, as I will show you later. So this is from the guidelines that we published, I guess, a couple of years ago in Circulation by the American Heart and other societies, American College of Cardiology also. So there's some very distinct cardiac rhythm abnormalities, and there's no dysfunction. So one of the hallmarks of heart failure with Chagas is that these people come in severe heart failure, but they're usually bradycardic. They don't have sinus tachycardia, which has been an issue for the treatment mostly with beta blockers. They do have bundled branch block, and most commonly, although nothing is pathognomonic, they will have a right bundled branch block with a left anterior fascicular block. They will have lots of ventricular arrhythmias, and about 10% will have atrial fibrillation. Lots of segmental wall abnormalities, some of these related with the distribution of the autonomic innervation between the epi and the endocardium, and not going to get into the details of that, but we get lots of apical and mostly inferior posterior aneurysms with a dilated cardiomyopathy that may also lead to thromboembolisms as part of the hallmark of the disease. Now, the disease is endemic in Latin America, so Mexico down to, there's not a lot of this in Uruguay or some in Argentina, because in those countries, there is more active vector transmission elimination, which pretty much never happened above the equator. That would be somewhere around here where I'm trying to point. I know John Thyberg is going to ask me why I'm not using the little red dot, because I couldn't find it. But anyways, so, but there is a Chagas in North America, and there's approximately 400,000 carriers of T. cruzi in the US. So it is the most common parasitic disease in the Americas, and it is the leading cause of infection, myocarditis, worldwide. So today it's about 7 million people that are at risk of having Chagas cardiomyopathy. And as I mentioned, only 20 to 30% will evolve to cardiomyopathy, but these have significant morbidity and mortality. And there's only 2 registered compounds, Benznidazole and nifurtimox, despite the fact that this disease has been around for over 100 years. So how did I get into this? This was back when some people may or may not know that I did spend some time at the Medical College of Virginia doing mostly autonomic stuff with Dwayne Neckberg. Dwayne had actually done some of the first descriptions with Eugene Braunwald of alterations in autonomic function in heart failure back in the mid-70s when they were both initially at the NIH and then in San Diego. And then when I came down there, one of the guys down there in Columbia contacted me because I was doing mostly autonomic dysfunction. So we looked at a series of patients that came from this place called Bucaramanga in the northeastern part of Colombia. And we did some heart rate variability. We looked at baroreflex sensitivity. And these were people that, Chagas 3 were the advanced heart failure or that had already some arrhythmias. And you can see there were some alterations in their autonomic control. We then came to try to see if we were able to identify early autonomic changes in people that were in the subclinical or in that indeterminate stage. And again, we were able to do a battery of autonomic tests that include baroreflex sensitivity using nitroprusside and phenylephrine, cold phase tests, and other things that we do today here at the Satish's Autonomic Lab. So that's how I started getting involved in this. And I also looked at I was also already fascinated with the modulation of sympathetic nerve traffic and its relationship with baroreflex modulation. And we had done some initial studies of pacing and sympathetic nerve traffic when I was in Virginia with Andy Taylor and Ken Ellenbogen. And we tried to reproduce some of this in these patients, and they had some very characteristic differences in the way the sympathetic nerve traffic and blood pressure was managed and recorded, and we did some of these findings and reported some of this. This is 20 years ago. Wow. So anyways, we looked also at some of the dynamics of heart rate dynamics because one of the hallmarks of Chagas cardiomyopathy is indeed a cardioneuropathy. And we looked at some of the alterations in heart rate dynamics before spontaneous VT and VF that we recorded from ICDs and patients down there when I was down there. So we used some of that and looked also at baroreflex sensitivity. And you can see that these patients had a very reduced baroreflex sensitivity back then, which gave us some ideas to try to modulate these reflexes. And we did a small placebo-controlled trial with IV metoprolol in these patients, looking at whether we were able to modulate some of these reflexes and try to reduce VT and reduce the incidence of sudden cardiac death. And we also looked at the autonomic dysfunction and vascular dysfunction, looking at foreign blood flow and peripheral vascular resistance using not only tilt but lower body negative pressure back then, and recording sympathetic nerve traffic, and came to this hypothesis that cytokines and INAs and ADPH oxidase could lead to some of these metalloproteinase MP2 and MP9. And Rick Schultz is on the call, and we did some work together looking at this and in different stages of Chagas, and I may show some of that data, I think. Anyways, that led to the Charity trial. That was the first trial that I kind of designed way back then. I started the design of this, I think, in 96 or 97 before I went back to Columbia. And this was a double-blind randomized controlled trial of bisoprolol in these patients that were in these different stages of New York Heart Association. We did recruit 500 patients. Unfortunately, never been able to publish anything on this because Well, way back then in the mid-90s, things were not very good with the guerrilla in Colombia. And most of these patients came from areas in which there was a lot of FARC. I didn't factor that in the design of the trial. So unfortunately, the loss of follow-up was massive, and I couldn't really get a lot of the data. I do have some of the safety data, which was good because there was a lot of hesitancy to use a beta blocker in people that have sinus node dysfunction and sinus bradycardia, but we never saw any signals on safety. But again, challenges that you find when you're trying to deal with some of these neglected diseases. So then I turned out into, when I started thinking about benefit was in the mid 90s. And then that's when I bumped into Salim at a meeting in Chile. And for other reasons, Salim knew me when I had done my training in London. And he also knew my father, who actually was the CEO of something called INCLIN, the International Network of Clinical Epidemiology. And some of the first funding for the InterHeart trial came from INCLIN. So, I had a good connection with Salim there. And we decided that we wanted to go into Chagas with his friends in Brazil. And we tried to expand this through Latin America. But there's a lot of resistance way back then. Matter of fact, we had a lot of people that felt that doing a randomized placebo-controlled trial in people with early stage cardiomyopathy was not ethical, that all these people should receive anti-parasitic treatment. So I had to go down to Argentina, Brazil, visit a lot of sites and do some smooshing there to try to convince some centers to actually participate in the trial, because there was a group in Argentina that was led by Dr. Viotti, who felt that, giving anti-parasitic trial was standard of care in spite of no data from randomized clinical trials. So this was another challenge back then. But the new paradigm was that, this was not really only an autoimmune chronic myocarditis, but there's a combination of this low-grade parasitic infection, in addition with all this triggering of the inflammatory response that was mediated by the parasite. So this parasite persistence was probably the mechanism of the progression of cardiomyopathy. And if you got rid of the parasite, very much in a way of what, we felt in HIV, you never get rid of the virus. You just reduce that threshold of virus to try to reduce the progression of the disease. So we had that same kind of thought process when we were looking at Chagas cardiomyopathy. Now, although this was a study that came later, just because of the order and try to look at patients in the indeterminate stage. So we did the Stop Chagas trial. And again, I reiterate, we did this after we did benefit. But again, other challenges. So when we started this trial, the patent for Benznidazole was from Roche Pharmaceuticals. But and I'll tell you another story. When I go into the benefit trial, Roche had decided that they were not going to do this for many reasons. And this lab in Brazil was producing Benznidazole. But in case you don't know, Benznidazole is usually given in a 5 milligram per kilogram dose to a maximum of 300 milligrams a day. So what happened is that this lab that was doing this medication was producing tablets that were 200 milligrams, and you could not really cut them down or create this dose that was adjusted by weight. So we only had a dose of 400 milligrams a day. So as you see in the names of the people that participated in this trial, our friends from Brazil also felt it was unethical to participate in this trial because we were using a high dose. Usually the max dose was 300, we were using 400 milligrams. So again, another challenge back then. Now, just to remind you, this was a trial that, again, small trial, but 120 patients that included Mexico, Argentina, Colombia, El Salvador, and actually patients from Spain. This was the first trial design in which, patients in the indeterminate stage, so in other words, patients that had no ECG changes or no echocardiographic changes, but that did have positive serology, were randomized to 4 branches that included, a combination of posaconazole and benznidazole, benznidazole alone, placebo alone, and again, a lot of resistance on just giving placebo and posaconazole alone. Now, our main primary outcome was efficacy, looking at the response to the PCR in of the response to any of these medications. So trying to look at the reduction in parasite load in negativizing this. Now, again, this was a younger population than benefit, as I will show you in a little bit. The mean age was only 38 years. These were people from Argentina, Chile, Colombia, Guatemala, Mexico, and Spain with normal LV function and normal ECG. We looked very carefully at the QT because, as you know, posaconazole can prolong the QT. And these are people that, although they were in the indeterminate stage, we had shown earlier that there could be some QT dispersion in patients or in individuals with positive serology. So this study, what it showed was something very interesting, was looking at the PCR percentage of negative PCR. And you can see here, this is the placebo group, so very low conversion. And then there's some spontaneous, not conversion, but it's related with the threshold of detection of the load of parasite. But you can see that very early on, within 30 days, there's already a response. Now, the standard of care has always been 60 to 90 days of treatment. But again, this came from just observational trials, never a randomized trial to determine what was the duration of treatment. And again, benznidazole is a significantly toxic drug, but you could see here that really benznidazole alone was very effective, not much of an addition with posaconazole that's here. And posaconazole alone, once you stop the medication, the negativity of PCR drops significantly. So there's, again, parasites in the bloodstream. So this pretty much was one of the ways of trying to design future trials and determining efficacy. Now, when we organized the benefit trial, again, this started back in the year 2000, and it took us several runs of grants through CIHR, Wellcome Trust, TDR, that's the Tropical Disease Research Branch from the World Health Organization. And, when I first submitted this to CIHR, one of the readers said, well, we don't have Chagas here, why do we care? And then I had to demonstrate that actually there could be Chagas in Canada, and the number of Hispanic immigrants in the last 10 years prior to submitting this grant was quite significant, and a significant proportion came from all these endemic countries. So that finally kind of struck a chord, and we got this grant funded by CIHR, with 2 or 3 renovations for the grant because it took a significant amount of time to do it. Now, we did publish this in the New England Journal. Again, when we designed the trial, we were looking at about almost 3,000 patients, but it was 50 sites in 5 countries. And we were, trying to find different TC cruzi strains so we could actually find some answers to a number of questions. So again, benznidazole 300 milligrams daily against a placebo group. These are patients with chronic Chagas cardiomyopathy in the early stages. Most of the patients were in New York Heart Class Association 2, and they had to have the typical abnormalities in the ECG and 2 positive tests with a primary outcome that was heart outcomes of death, resuscitated cardiac arrest, and you can read the other ones there. Now, when we started the trial, Raj had given us some drug and placebo, but at the middle of the trial, Raj decided, okay, we don't want to do this, and we don't care about this patent. So we were stopped for a few months until we found some company in Brazil to do the trial and to basically do the drug that we didn't have, and also the placebo. We never did some pharmacokinetics or pharmacodynamics to compare whether these two drugs were the same thing or not. But we did sensitivity analysis within the trial to figure out what was going on. And we did have a long follow-up, about 5.4 years, which was, significant when looking into Chagas. And again, this is the largest trial ever conducted in Chagas cardiomyopathy, almost 3,000 patients, about 55 years of age, in contrast to those that I showed you from Stop Chagas that were only about 38 years, because those are in the indeterminate stage. These already had manifest cardiomyopathy. Mostly males, were 50% were males, and with the typical ECG abnormalities, about 8% with atrial fibrillation, and with complex arrhythmias, another 15% or so, and 10% that had previous heart failure. And you can see that the vast majority were in class 1 and 2 New York Heart Association, with a low amount of patients with ICDs and about 15% with pacemakers. But again, this was medications. You can see obviously we started and randomizing patients like must have been 2004, I believe. So not a lot of new drugs, but about 50% were on NACE or NARB, and 11% on digoxin, and about 20% on amiodarone, which is a drug that is widely used in people with Chagas because of both atrial fibrillation and the frequency of ventricular arrhythmias. Now, again, the primary outcome was this heart outcomes, but we did have some secondary outcomes that were related with the efficacy of the treatment. Now, that's another story. When we first submitted the grant, well, I wasn't looking at any evidence of parasite reduction. And again, I don't know if you know or not, but really before benefit, the way people tracked reduction in parasites was very primitive. And what people did was, you just got a bunch of bugs. You put these bugs in a little container, bring them over to the patient, get the bugs to suck your blood, then take the bugs over, open them up, and then see if there's parasite and count them down. You can imagine that technique for 3,000 patients and doing looking at parasites, 3 or 4 times within 5 or 10 years was not tenable, and was not really something that should be done. So one of the things that actually we did in benefit is that I went down to Brazil, spoke with the one person that had presented some data on PCR, and tried to convince them to use PCR as our main goal for detecting parasites. But again, this is challenging because if you understand, the PCR looks at the DNA of the parasite. But this DNA of the parasite varies depending on if it's T. cruzi 1, 2, 3, 4, 5, or 6. So we had to actually create all these standards for the different types of T. cruzi. And that, was another challenge. Now, one of the main challenges you can see already here is that, when we looked overall in the upper part here at the reduction in parasite load after 5 years, you didn't see much happening here. But when you looked at Brazil, they seemed to be, a very significant drop initially, and then this was lost after about 5 years. And Colombia and El Salvador didn't have any change. So how do you explain that? And I'll get into that a little bit later. Now, there was definitely some interaction among countries, with some showing that in Brazil this worked. This led to a lot of political disarray within my investigators and my colleagues in Brazil and myself. And not going to get into details, but this, it's part of what happens when you do clinical trials internationally. Anyways, the interesting thing is that whether you had a positive or a negative PCR did not seem to affect the response in the long term. So again, a lot of stuff that we didn't really understand completely. Now, when we looked at the main primary outcome, that was this composite outcome at about 7 years of follow-up, again, huge follow-up. We only lost about 10 patients over all of the 2,800 patients, which is amazing. We had some we did invest a lot in cell phones and calling cards and things like that. We sent people to the fields to try to find the patients and follow them throughout the duration of the trial. So this was quite significant, but again, disappointing in a sense, seeing that there was some differences when you looked at the country PCR response. But then when we looked at by countries, looking at the primary outcome that was these heart outcomes, there was really no difference. And the only subgroup that actually showed some interesting interaction that was significant was the amiodarone. Now, again, you're going to ask, okay, so what does amiodarone have to do with anything? And there's evidence, experimental and clinical, that actually amiodarone reduces a parasite load and has some anti-parasitic effect. So there may be some synergism between amiodarone and benznidazole in that case, but this is something that still needs to be worked out. Again, this was from a publication that the Brazil group did. So again, this was an interesting fact that, we were, someday someone called me and told me, hey, have you seen the publication from the Brazilian group on benefits? And no. So they actually excluded us because they wanted to show that, apparently in Brazil this worked. Now, of course, if you look at the confidence intervals, that crosses 1, so you can say, well, probably there's no effect here. But again, there was a significant disarray in the sense that, the Brazilians continue to think that maybe this is something that works there. And again, we're doing some further studies to try to document whether this is the case or not. Now, in benefit, there's a significant proportion of people that died. That was, one of the main outcomes. And new or worsening heart failure was also quite significant. Now, one of the few things that we did see in benefit was that there was an impact on hospitalization for cardiovascular causes and the group that received benznidazole compared to the placebo group. But again, this may have been something just by chance. Now, again, as I mentioned you, while we were doing this study, we felt that, okay, we need to figure out a way to standardize PCR and real-time PCR. So PCR can give you positive, negative, but real-time PCR gives you the real parasite load. And one of the things that we actually noticed when we looked at in a subgroup of benefit was that there was a difference in the parasite load. And you can see that the parasite load was higher in Colombia and lower in Brazil. So was this connected to that response that I showed you that was, pretty significant in Brazil, but not as significant in Colombia and Argentina? Colombia, TC cruzi 1, Brazil 2, Argentina 3.5. Was that maybe the reason why this didn't pan out the way we wanted? And it was. And again, higher parasite load concentrations, maybe we needed more treatment. I remember that for a disease that's been around for 20 years, we only gave a 60 to 90-day treatment. Now, if you come to think of other chronic illnesses like leprosy, TB, that never happens. People are on leprosy treatment for decades until they completely eradicate the disease. So maybe that's what we did wrong. And we looked at it more as cardiologists, in which, you give a little treatment to try to get rid of the problem and then see what happens. So that's why we are probably aiming in on our next trials. Now, interestingly, we continue to look at some of what does the parasite load has anything to do with cardiovascular outcomes. And this is from my collaborations with the group in Colombia that I still work with. And this was looking at a composite outcome in a small series of patients that died, had transplant, cardiac transplant, or an LVAD. And you can see here in blue upper here are the undetectable parasitemia and those that had high parasitemia. And interestingly enough, those that had worse outcomes were the ones that had low parasitemia with, greater reductions in LV function. So how does that happen? And again, it may well be this low persistent parasitemia triggers some inflammatory response that has to do with this. And that's why we want to concentrate on trying to target this as a potential marker or a potential way of treating these patients. Now, we've done some further work on trying to risk stratify these patients. And there's many ways of risk stratifying these patients. We did a sub-study in benefit with echocardiography. So we did echoes in all these patients, and all these echoes were read in a core lab that was down in Brazil, in Ribeirão Preto. And we produced a study in which we looked at wall motion abnormality index. And as you can see here, if this wall motion abnormality index was greater than 1.5, you can see that the primary outcome occurred in 60% of these people by 7 years. And, you know, by just 4 years, almost 40% of these people are dead. So again, this is very aggressive and rapidly progressing cardiomyopathy once it's established. Remember that 90% of patients in benefit were in class 1 and 2. And by 4 years, you know, 40% are dead. So this is a very aggressive disease. And, you know, just by looking at wall motion abnormalities, this could be a way of risk stratifying these people. We've worked a little bit more on some of what we call the Bennis score. And we've have some score that's looking at all-cause mortality that has these different markers that included some ECG abnormalities and segmental contractility abnormality, and get a point score there. And also for the primary outcome that was, as you know, a composite of death, sudden cardiac death, heart failure, etc. And this has another point score here that we validated there. And you can see here again, if we risk stratify this, depending on whether you have a score greater than 12, greater than 4, or a very low score, those people that have a low score have a very low risk of mortality. By 6 years, only about a 5% mortality. In contrast to those that have a high score greater than 12, you know, by 3 years, there's already almost a 30% mortality. So by 6 or 7 years, 40% are dead, and almost 60% have had one or more of the primary outcome indexes that I already discussed. So Bennis score is the only score that actually includes patients from different countries with different T. cruzi strains. So we think it's pretty good and well validated. And we've done some, you know, everybody is working on machine learning and artificial intelligence. So we're doing the same also. And we applied this with the benefit score and some other cohorts in Colombia. And this has been nicely reproduced here. Now let's go back to the issues with inflammation in cytokine profiling. This is one of our benefits of studies that we did at the beginning, and we reported some of the changes. And Dr. Epstein last week did mention something and some of the collaborations that we're already starting with him and his group. And this pretty much shows that, you know, as cardiomyopathy progresses, there are significant changes in different of these inflammatory markers. And these pro-inflammatory cytokines are seen more frequently in those that have myocardial involvement. And the higher the stage of involvement, the higher the number of pro-inflammatory cytokines. So we are aiming to, and we are already going to start an experimental study with, you know, a murine model that we helped develop back in Colombia, in which we're going to look at some of these cytokines and use his NK killer cell kind of modulator, and use a combination with parasite inhibition compared to a placebo group to see if we can find some answers there. Now, the other things that we're doing, and it's taking us some time, mostly because of the difficulties, not only in the technology, but also in funding, is the genotypes of the different DTUs, the different T. cruzis. So we already have some of the data now, and this seems to show that some specific DTUs will have a different progression of the disease and a different response to treatment. So we can do some more personalized precision medicine also here in Chagas cardiomyopathy. We've also been looking at profiles with biomarkers that are related with the stage of cardiomyopathy. And again, this is with my group down in Colombia, in which we've been looking at NT-proBNP and some other biomarkers that you can see there. And these pretty much correlate quite nicely with the progression of the disease. So I think that targeting some of these and other biomarkers that we've looked in the past, and here's the MP2s and NMP9s that we did show very nicely, and that was with Rick Schultz's group and some other people, that there was some interesting correlation with echocardiographic and wall motion abnormalities, as well as progression within the different stages of the disease. Now, the question is whether targeting these MMP2s as a therapeutic strategy will eventually reduce the progression of the disease, as something that is work in progress, and hopefully we'll get to that. Now, we've also looked at some other fine ways of combining, also looking at the genomic expression and other potential biomarkers that we continue to work constantly on this. And of course, the most clinically available ones would be echocardiography. And again, this is from our group in Colombia. We've been looking at some of the echocardiographic parameters and speckle tracking, correlating this with brain natriuretic peptides and the levels of progression from the indeterminate stage to Chagas cardiomyopathy. Because one of the challenges has always been, okay, how do we know those people in the indeterminate stage, supposedly with no significant cardiomyopathy, are going to be developing the disease? So we've been looking at this and nicely showing that some of this global longitudinal strain may be able to predict the progression of this. So last few minutes, I'm going to go into heart failure. And this is a summary of the very few trials in heart failure that are very small, very few randomized trials, actually, only a couple looking at different interventions for heart failure, mostly captopril or carvedilol, but with very limited data. Now, from benefit, we know that there was a significant difference in the way how people treated these patients. You can see that ACE inhibitors and ARBs, for example, in Argentina and Bolivia, only 23% or 24% were on these agents. Amiodarone, 30% in Brazil, only 8% in Colombia and El Salvador. So these differences, and according to LV function, also marked differences with very significant interaction values, which make us think that obviously there's lots of work to be done there. Now, this Chagas heart failure, is it different from other cardiomyopathies? And yeah, there's some interesting data that show the progression of the disease is faster, the need for transplant is faster, and other markers. And this is from some combined studies in which a few patients with Chagas were included in the Paradigm and Atmosphere trials. And in summary, they show that they have a faster progression of cardiovascular death and heart failure. The red is the Chagas cardiomyopathy people in the different outcomes: heart failure admission, all-cause death, etc. So this population definitely behaves differently. And this is some post hoc analysis of the Paradigm heart failure with reduced heart failure due to Chagas. Again, very small group with sacubitril, valsartan compared with enalapril, showing some effects that probably were beneficial. So that's what triggered the Parachute heart failure trial, in which, again, I am one of the co-PIs. This is being coordinated by Dr. Renato Lopez from both Duke and his center in Brazil. And it's a composite primary endpoint with a hierarchically ordered a composite endpoint. I won't enter into details, but again, sacubitril, valsartan against enalapril in about 1,200 patients with Chagas cardiomyopathy heart failure. So this trial is ongoing. We've already recruited patients in these countries. We are already in around 120 patients. Here from the Libin, we're going to be the central coordinator for the Holter sub-study and the biomarker sub-study that I'm funding out of my professorship money, but that's how we do trials in neglected diseases. We put our own money so that this happens. And Novartis has helped with some of this. So we are already recruiting patients, already around 150 patients patients, and this is ongoing. Sudden cardiac death, again, is very important in Chagas cardiomyopathy. Is the Meyerberg famous diagram adapted to Chagas cardiomyopathy. And I did show you some of the initial data that we did with heart rate variability and dynamics of heart rate that were actually with Dr. Meyerberg's group back in the early 90s. Another thing that we did were the first recordings of monophasic action potentials during VT. It was my friend Michael Franz, who was the one who designed that monophasic action potential catheter. We did some of these recordings back there in Columbia showing some delayed potentials. In these patients, we compared patients with Chagas and patients with other cardiomyopathies, mostly ischemic cardiomyopathies. You can see the difference in the number of shocks. These patients get way more appropriate shocks than patients with a non-Chagasic cardiomyopathy, like almost a 200-fold increase, which obviously creates some problems. And this is one patient back in almost 22 years ago. This lady had over 100 shocks that were all appropriate within 24 hours, but she was in an area of the gorilla, so I had to negotiate with the gorilla people to be able to get a chopper in there, bring her in and put her a magnet and bring her into our hospital for some ablation and other things. So again, challenges that happen there with this disease. And again, MRI has been shown to be quite useful in trying to detect some of the abnormalities. And this is some of the studies that have been done from some of my colleagues in Columbia, trying to identify not only these areas of interest for ablation, but that can also provide some information on correlation between MRI abnormalities and EP study abnormalities, and looking at whether these are subepicardial, midwall, subendocardial, or transmural. And you can see here at the last column, the summary where about 45% are transmural and a significant proportion midwall, which help guide where we go. Now, other areas that are of interest is that still within the context of people that present with ventricular storms, there is significant ongoing inflammation and fibrosis. So that's why all this connection between inflammation, autonomic dysfunction, and fibrosis, which has always fascinated me. And we were working on trying to unravel that mystery and using different techniques to identify these patients. And this from one of my former fellows and med students that published this recently in JACC, very nice review on arrhythmias in Chagas cardiomyopathy. Again, VT, multiple VTs that are related with these areas of fibrosis and these areas of scar that are usually inferior, posterior, or apical, show that, newer technology, you can adapt these mapping systems, both epi and endocardial, and correlate with MRI and target these tachycardias. So some proposed algorithms for the treatment of ventricular arrhythmias in chronic Chagas disease include endo-epi mapping, and there's randomized trials showing that this is useful from my friends in Brazil and in Colombia. And again, this from my colleagues in the center, which I also work with, looking at cardiac sympathetic denervation as a treatment in these patients with a ventricular storm, and bilateral renal denervation. This from Dr. Luciana Armaganijan, who's in Sao Paulo, Brazil, who I also had the pleasure of training. So again, there is some combined cervicothoracic sympathectomy and cases, renal denervation, and endo and epicardial with a randomized trial, very small, showing some of the techniques that we can use in these patients. And again, heart transplant, these patients do relatively well. This is from the series that we just published from the center that I collaborate back down there in Colombia, looking at this group of patients. So where are we going and where are we at? There's lots of stuff to still be done. Benefit definitely triggered a lot of interest from industry and others. And, Stop Chagas, Bendita, all these trials are currently ongoing and are looking at different combinations, shorter courses, pulses of therapy, longer term therapies, and what we call Benefit 2 down here, in which I'm working on trying to fund and developing for the next probably decade of my life. And again, we've been involved with these trials that have led to a lot of changes in guidelines and other areas. So in summary, a significant proportion, about 30%, have cardiac damage. There's a lot of alterations here that may be related with the inflammatory pathway. The systemic parasitism, which is a low-grade parasitic infection, probably is related with this chronic cytokine involvement. So if we do a combination therapy there, we may be able to kind of modulate these. MMP2s, MMP9s are here also. So these patients have worse prognosis. We're going to be able to modulate this by doing that. So definitely new trypanoside therapy, our combination, this is what we're thinking in benefit 2. Are we going to do a combination of chemotherapy and immunotherapy, and maybe a poly pill in which we have these modulators of inflammation, fibrosis, and parasite. And also, of course, contemporary therapy for the parachute trial is going to be definitely critical. So as paraphrasing Gabriel Garcia Marquez, who's Colombian, and I had the pleasure to meet many years ago, 111 years of solitude, I think, have come to a halt with a lot of things that we've developed, and starting with benefit in other trials. And, this has sparked significant interest in the community to try to eradicate, hopefully, the disease from the face of the earth in the next few years. So this is a Heart Institute where I was the scientific director a long time ago, and I'm still on the board there, where we developed most of these autonomic function tests in our initial clinical trials, and then PHRI, and of course here and now, in which we are developing other trials with biomarkers, and not only that, but also Holters of studies. And of course, all of the people that have collaborated. This is a teamwork. I could have never done this on my own. And it's a huge team of people that I trained and have gone on their own way to do bigger and greater things, not only in Chagas, but in many other diseases. And this center here that's developed into this new center in Colombia, where I do some of this Chagas stuff. So again, thank you very much for your attention, and hopefully you get to recognize a few here. When I first came to Calgary, I got a call from the consul in Alberta and told me that there's 40,000 Colombians in Alberta. So there's probably one or two with Chagas out there. So I don't know if there's any. Do you recommend prophylactic anticoagulants for Chagas dilated cardiomyopathy? Yeah, good question. But no, we're not recommending prophylactic because most of these are going to have these chronic laminar thrombus that we think are not as thrombogenic. Do children with congenital Chagas with complete heart block require pacemaker, or is it reversible? Great question. What we know is that, if they have complete heart block, they're going to need a pacemaker, which is always a challenge. But actually, you can prevent a lot of that by treating these young kids once they're born with Benznidazole. There's a data that, and is even further, treat the mother before they're pregnant. We are able to prevent this from happening. And Russell, do simple interventions like insecticide treated bedness have a benefit in preventing the disease? Yes, of course. That's the way to prevent the disease. But again, politics. This was what happened in the southern corn. That's why southern corn, that's when in Uruguay, some areas of Argentina, in some areas of Brazil, you don't see that. But again, as soon as the politicians change, something as simple as, spraying insecticide. But then, the other things with this insecticide is that it's not very environmentally friendly. So really, it's a disease of poverty. So if you just get rid of the parasite and give people better housing, we were probably not talking about Chagas disease. Anyways, other questions? Apparently not. Well, thank you guys. Hope you enjoy the rest of the day.